Grateful to Sreekumar and Nair sir for having made it all the way from Jipmer at such a short notice because he has gracefully accepted it, and he is the professor and head biostatistics from Jipmer Puducherry, and he will be taking to us through a difficult topic on cancer epidemiology. Again, as we have seen part of Prashant's presentation yesterday, that you can expect 2 or 3 short notes from this session. So we hope that this presentation also will be useful for you. So over to you, Nair sir.
Good morning, everybody. Thank you, Rajiv and Vishwajit, who made it possible for me to be here with a surprise. Because it's you know that it's from there. I'm a biostatistician. I'm not a cancer epidemiologist. So I want to tell that it's very clearly to you. Okay. So I thought initially statistics I'll be talking. Then I got the epidemiology I have to. Epidemiology no problem for me. But I haven't much worked on cancer epidemiology. I wanted to tell at the beginning itself, okay? Except, yes, I have a lot of good friends, like Swaminathan and so many. I mean, it start from Gangadharan sir, who is working in Amrita now, cancer epidemiology, cancer registry. So I have good friends, lot of, it's cancer epidemiology, but I haven't done much in cancer epidemiology, but of course epidemiology. Then I got the short notice. I was thinking, it's okay, what to do and how to do. Then I had a talk with them. Yes, your exam going. Okay, so we keep interacting with the exam going postgraduates. It's not just a oncologist alone. It's all Jipmer we have and many other places we keep on going. Okay, so what I overall framed for 45 minutes is this. A little bit I start with epidemiology and basic concepts of that. Okay. Then I got some, even all of a sudden, some WhatsApp messages. It's asking for some of the fact sheet from cancer epidemiology. Yes, that's a place. Thank to Dr. Swaminathan. Some of the data slides I got it from him. Okay, so you have a part of conceptual thing, and then you have part of little bit of data set, and a little bit of statistics part. That is what I thought of doing it. And as I change, usually it's 45 minutes. I talk with the 10 or 15 slides, but you find it's some more than 50, 53 slides. But I won't be talking on. But why I put all those slides is that is available to you. It can be circulated and you can read those numbers again and again for the preparation purpose. But my focus will be more on the few of the concepts in those calculations, and that's the way I try my best to do justice to you. Okay, and see that, and in between, if you have any need any clarification, yes, I'll be happy if I can do something. Okay, so that is with that understanding we start. Okay, and I think it's probably you have to agree with that. I'm not asking everybody is agreeing or not. You have to agree. That's the way we proceeded. Okay, and this is a way I some of these areas you know well, but still a little bit of briefing, because those are the concepts, even though we know from the undergraduate days, but there are some confusion. We try to clear this area. Then little bit about the epidemiology and registry, and some few points, just 2 or 3 slides about the statistics. It's already I know that it's yesterday you had a session on statistics, and so you must have come. And definitely, without thanking Swami, I cannot move further, because it's many of the slides or data I'm using, it's from him. Okay, so I obtained from him. So you can tell that even though I'm using it, these are authentic things, because it's coming from Swaminathan. He worked so many years in the registry. Okay. Now, if you, it's wanted to read a little bit, even it's 1.5 days, you can finish this cancer epidemiology, this book. It's many of you must have read. It's available. You can download it. It's a free download available in this. And many of the data, yes, you get from these two. It's so, you can clarify with these things. Okay. Now, I think it's all of you are familiar with this slide, okay? And you attended examination. It's many times with these slides. Basically, when we talk epidemiology, even I was fortunate. It's morning. It's even first talk on was sitting here. Lot of epidemiology concept, lot of epidemiology people talked here. Already yesterday also you must have talked, okay. But basically epidemiology, what is this? One is we look at the distribution. That is the most of the talk I seen that one, distribution. In terms of percentage, in terms of proportion, yes, it's a what, different type of cancer, it's how it is distributed, all those things. So that is basically magnitude we talk. And then there is another term called determinants. That is a place we go for something called which are the factors responsible for it. You look at it, it's okay. If this is a magnitude in this group compared to the other group, yes, can we identify some factors responsible for it? Okay. So that is what determinants. And these two together almost complete epidemiology. And this concept, when it comes to cancer, that is any disease. In fact, it's at present, people talk in terms of very much social epidemiology. Okay. So any disease it comes, it is called, for example, cancer, it is there, it's a cancer epidemiology. So basically it moves from general to this specific. Now, what I thought is to start with, before we move to those determinants or distribution, from the epidemiology point of view, you have to understand few terminologies. I think it's very important in the examination point of view, because we know these terminologies and we definitely get confused with this terminology. That's a problem we find. You know that very well. Or at least I assume that I know it very well. But when I use it, someone else who know better realize that, oh, this fellow is talking nonsense. It's okay. So when you talk epidemiology, I think don't talk very loosely. You have to have each and every word you use very carefully, because these are technical terms. I'll come to that. For example, there are some word called exposure. Later, almost all slide I will be using it, exposure. So you know that. And outcome, you know that. Okay. I'm using a word, what is the type of exposure variable? When as a statistician or an epidemiologist, when I look at what type of exposure variable, it could be little different from you look at it. Okay. For example, smoking is an exposure variable, and I know that doctors say, yeah, smoking, that's it. But for me, smoking alone won't give. Basically, how you measure that. Smoking, yes or no? Or smoking dose you quantified? Or how it is. That is very important for me to get that concept of epidemiology. Otherwise, smoking is a factor. But smoking, how it has been studied? It is just yes or no, or never versus it's the previous smokers versus present smokers, or really there is a dose calculation as done or not. These three things make a big difference for as an epidemiologist for me to connect this exposure with the outcome. Outcome, it could be the person developed the disease or not. So this is, I'm not going to the details of this, but the moment you use the word exposure, you use the word measure any exposure, okay? You have to have, as an epidemiologist, if you are looking, you have to have this principle in mind, okay? That is what. This all. And how long? Sometimes we miss that. Smoking, yes or no, but how long? Last 10 years, 5 years, and my question to you is, really you want to incorporate that duration also in the analysis when you look at it or not. If you want to incorporate accordingly, so probably analysis will change and the results will change, okay? So that is very, so this is one important variable I'm interested, every epidemiologist is interested, and then the outcome, or sometimes you call it as event, whatever it is, because it's always you are oncologist, you are looking at long term. I mean, you have a long duration, not like that. It's within 10 days things happens after exposure, or within 6 months things happen after exposure. A long exposure, and after that it's a event happen. And event also how it is measured, that is very important. Again, just like exposure measured, it is okay, present or not, or magnitude of the disease exactly you have a classification or not. Basically, that is like these both things will change the whole analysis, the whole epidemiology, the way we look at it. Okay, so then how you? I'm not going into much details of this. This you know that, and it's you can read it from the earlier materials, questionnaire, interview, telephone call, diaries, record. So there are various sources we use to get this information. But this is an important, crucial question. Okay? And how reliable and valid this information is. And if anybody think this, okay, by increasing the sample size, okay, or sometimes people tell, okay, I use the best analysis, Cox regression, or all those things. By doing that, if you think that you can control this error, no. Okay? No. Because if garbage you process, you get garbage only. Okay, so make sure that reliability and validity of the data, that's it, if you wanted to talk epidemiology. That is very important, okay? Now, with that introduction, there are the epidemiologists look these three words differently. Sometimes you look, all three are more or less same. Okay, but epidemiological way, when you look at it, a proportion in the school days you have seen, there is a numerator, there is a denominator. Okay? There is a numerator, there is a denominator, and the numerator is always a part of denominator. A simple example I can tell, how many men here out of total? Okay? So total when I count men and women, and then numerator when I take men. Okay? That is a proportion. It is a very simple proportion. That's, but when it comes to rate, it's a little more, it is there. There is a time also coming into picture. So I find many times people shift from proportion to rate and rate to proportion. But yes, proportion you can tell it's also a rate, but it's rate you can tell it's also a proportion. But all proportions are not rate. For example, now here, how many men, what proportion of men out of total, it is not a rate. So as simple as this, okay? And this rate always in cancer you use it because time is an important integral part of all your measurement. All your event measurement, time is an integral part. That is why you use rate, okay? Then there is something called a ratio. And when a ratio comes, numerator, for example, you know, sex ratio, people talk about sex ratio. There, numerator is different, denominator is different. Okay? Even mortality, that is another statistics you deal with. Many textbooks, many times you find mortality ratio. And very carefully they put that word ratio. The simple reason is that numerator is not actually a part of denominator. Okay? Or there is some amount of overlap, but not numerator totally from the denominator. So you have to, sometimes even mortality, if you look at it, mortality rate sometimes people use, mortality ratio they use. Please understand these are different, it is not same. It is not same. Mortality rate when they use, they are very clear. There is a denominator and the numerator, how many died out of this denominator. That is what, okay? There is a cohort. I'm coming to that. Okay? But when we talk ratio, that numerator need not be a part of the denominator. Okay? So there could be some overlap, but not totally derived from the denominator. So don't think that, okay, in textbook, one place they used mortality ratio, another place they used mortality rate, it's both are same. No, it is not same because there is a clear difference in the denominator. concept. Okay. So with those three words, yes, these are the, cancer statistics or any statistics you look at it, yes, basically these are the three words playing a role. Okay, basically these three words, and based on these three words, other words, other terminologies are made. Okay, other definitions are made. Okay, that is why move to this. Okay, prevalence. All of you know it, and we talked about the prevalence a lot. It's okay. It's and you every day you read it. Okay, and you know this definition of prevalence. Okay, so just look at it. It's a particular time point. A particular time point. It is not a duration. A particular time point. What is the population? Out of that, how many are with that condition? It could be new case, it could be old case, all put together with that condition. So, and you use prevalence of various type of cancers. Okay, so please understand, it is need not be new, it be old, or I don't know, it is new or old, but all this is the in the community level, or this is the burden. You can tell this is the burden of disease at present in this district or this state or this country. This is the burden, you can tell. It could be new cases, it could be old cases or cases. Okay, and it depends on its how rare is that condition. It is expressed in terms of percentage or per 1,000 or per 100,000, like that. Cancer usually expressed in terms of per 100,000, and some other diseases, leprosy and all those things, in terms of 10,000 or like that. Okay, infant mortality, if you look at it in terms of its 1,000 live births, it's used, and some of the common, for example, diabetes, hypertension, all in terms of percentage it is calculated. So 100,000 or in terms of percentage, it depends on how rare or how common that condition is. It's coming. Okay. Then, yes, this terminology also, it's not very common, but it is used in the literature. You find periodic prevalence, and this is basically, it's at one time point you cannot measure it. Over a period of time you measure it, but still your idea is what is the magnitude or what is the burden of condition in this community. But it may take a 6 months or 1 year survey type of thing. Okay, so that it is not very common term, but it is rarely used, the periodic prevalence. Okay, but whenever prevalence comes, it's just understand it's what is there in the basket overall. That is what you are looking at it, and that will help you as a healthcare professional, yes, to roll out the strategies to management. It's how to do that. Okay. Shall I move further? Now, there is something called incidence. Okay, look at it. This again, it's coming as a proportion. Incidence. The word, when you use incidence, yes, it is, you are focusing on new cases. Okay, and numerator is how many new cases. Here I need somebody to discuss on this. The numerator, new cases in a specified population over a period of time. Now time, I just brought in time into it, and this is a starting point. Okay, how many you started with, and they should be disease free. Is it okay? Clear that one? It's this is what incidence. It's because it's you talk about cancer prevalence, you talk about cancer incidence. Okay, and incidence, when we talk cancer incidence, it's and the denominator it is coming. Yes, it's a total you start with. For example, this year, what is the incidence, or the last 5 years period, it's what was the incidence. How many people developed, how many people who were at risk of developing really developed the disease? Okay, now I ask you at this point, I ask you a question. Okay, what is the use of this? Can anybody respond? Once we have prevalence, you know the magnitude, you know that you can manage things. But why should we bother about it? Because incidence, you know, last 5 years, how many new cases developed to calculate it, really that survey is totally a different one, and you have to spend a lot for that. Why should we spend for that? What's the reason?
Change in incidence.
Why you want to know? It is a measure. Huh? Huh? Screening can be concentrated, but why you want to know? Huh? Why you want to know this number? Why? For example, you are with the cancer control program. It's you are heading the cancer control program. Why you want to know this number? You know the magnitude and you can do it.
With the measures what we are taking is
What it gives exactly?
whether our treatment is working, incidence is decreasing or not, with the effective treatment.
Is it coming down or it's changing or not? That means you see, you don't sit quiet, isn't it? You have a lot of intervention programs, isn't it? For example, cancer control program, isn't it? That program working or not, what is the indicator it gives? For example, examination, there is a question, which is one of the epidemiological indicator which give cancer control program working or not. Incidence is the one. If you have incidence, it is coming down, and you have developed a cancer control program running last 10 years or 15 years, and incidence coming down, that means there is something to say, or there is a change in incidence. You have to talk with that. You cannot. I mean, you understand? That's it. So these indicators has got a specification for what. And prevalence give more about, okay, at present this is a system, and it's how it's, I mean, what resources you require and what all those things it's, and you have a cancer control program, but in spite of that, it's the incidence is going up. Oh, you have to relook at it. It's not blame the program, but there is something else also happening. Yes, we have to relook at our program and sort this. Okay, so what I am telling is these indicators, epidemiological indicators, you have to look in a different way. Okay. Probably initial slides I take few minutes, but after that I can rush through it. Okay. Then something called, so here you look at it, numerator is a number, denominator is again a number, and time duration is there. Okay. So it is incidence, there is a duration, okay, but numerator and denominator, again I am repeating, it is a number in terms of number of people, okay. But when we look at cancer or any these type of chronic diseases, yes, it is not, it's, and you follow them up, it is not everybody develop disease at a clear particular time interval. There are different people at different time interval it develop, isn't it? Okay, isn't it? Okay. Now, isn't it wise to account that information also when you calculate incidence? Otherwise, when you tell this magnitude, there is a problem. This out of this, it's suppose it's a 20. The numerator happened to be 50 individuals. That 50 at a different time developed. The first one person maybe it's within last 2 years developed, another person maybe 5 years, like that. Duration is different, especially when we talk about the chronic diseases. Okay, when we talk about diarrhea or when we talk about that type of its acute conditions, this problem won't come. But chronic condition, we have to account duration also. Okay, that is a place incidence little bit shifted then yes. How long, denominator is how long followed up. More description of this, it is there. You can read it. This slide will be given to you. It's there. They will give it to you. But denominator, it is not number. How each person, how long followed up. And once the person developed the condition, then after that you are not interested. You are interested in treating that person, but as an epidemiologist, I mean, you are not interested. The person, it is developed the condition, yes, it's the person is out of your, this one, okay. So that, and all those durations, and then numerator, it comes the number, and this is usually incidence rate, it is called. That is what I think it's, you are so familiar with person years, isn't it? It's, I mean, it's whoever is working in the cancer, yes, you are very familiar with, it is expressed as per person years, okay? When you call it per person years, please understand that each individual's duration of follow-up added together, and that is the one it's taken as the denominator, not exactly number of individuals taken as the denominator. Please understand that, okay? So there is a huge shift the way you express these rates, okay? Incidence and incidence rate, okay? Shall I move? Okay. So these are the measures, okay? Any question there? Anything? Okay. Shall I move quickly? Now onwards, it's very quickly I move it. It's because it's many epidemiological parameters I said. Okay, there are various study design. You are familiar with that. Observational studies and experimental studies. Yesterday you must have had a full session on experimental studies. So I quickly move to the observational studies, and out of that, it's mostly, the descriptive studies. It's after that, it's one is cross-sectional and prevalence. It's studies we call, or case report, case series. I think it's you must have presented many case report, case series, so I'm not talking about it. But only one word, the sentence I want to tell is this: if somebody think that it's very inferior studies, it's not. These are the studies really like a nucleus. It develop the whole epidemiology part of it. Okay, so case series and case reports, very, very important origin, which give other studies, life to other studies, okay? Cross-sectional studies, yes, this is why it's when I talk these designs, these terminologies are important, exposure and outcome, all those things, that is why we talk, okay? When you do cross-sectional studies, one of the thing is the exposure and outcome at same time you are measuring it. You know that phenomena and what it is, okay? For example, look at it. It's a cross-sectional study, and yes, HPV positive or negative, and basically two group of people, they looked at it, okay? At the same interview, they looked at it, it's HPV positive or negative, and the same time, same how many partners they have, that's looked at it, okay? You can call the prevalence of these conditions, that is all right. Only message I wanted to tell is, if you know, never overdo things. This is one advice I wanted to tell to the postgraduates. Never overdo. That means this is a cross-sectional study. It has got a power to do up to this. But after this, you do a test of significance, you do a hypothesis test, you are overdoing, you are overstepping it. The study won't give power to do that. Your study design is not powered to do that. So don't do that. A chi-square here, one can look at it, confidence interval create, and all those things, and tell, oh, there is a strong association between this. Somebody tell, no, this association, the study, association might be there, but your study doesn't give power to do that. Okay, so please understand that. Okay, then which study? Again, descriptive studies are very important. It again gives that. In fact, cancer epidemiology, you look at it, 75% are descriptive studies. It's cancer registry mostly give descriptive studies. All cancer registries mainly descriptive studies. It is not proving a lot of hypotheses, but it give enough data later to design studies to prove hypotheses. Okay, so descriptive studies are that way. It is very, very important. Okay, then other set of observational study, what you move is, it's called analytical studies. And the term analytical means, yes, there is an underlying hypothesis, and you can test that hypothesis, and you can see that is. Which part of that epidemiology definition that will come? Analytical studies. Can anybody tell quick answer? Analytical studies. Epidemiology, there are two words I said, isn't it? Which are those two words? Determinants. So distribution, lot of things we said. So analytical study, where it comes? Determinants. So far we were talking about the distribution, magnitude, all those things. That is the descriptive studies. Now these analytical studies give about the determinants. So many of the risk factors when you talk, basically it should be supported by an analytical study. Otherwise you cannot tell. Okay, the study won't give power to tell you is a risk factor. Okay, and most important analytical studies are a case control cohort, and then it's a nested case control study or so. When I should stop? Because we started a little late, so when I should stop? You also did not calculate. Okay.
15 to 20 minutes, yes.
From now. 12.5. Okay, okay. Okay, so case control study, cohort and nested case control study, these are the very powerful observational studies. These are observational, not experimental design. That means it's as an investigator, you are looking from side. You are not involving yourself. You are not doing any allocation or the. It is more a natural experimental situation. That's the individuals are experimenting themselves. Okay, okay. I drink or I smoke. It is my business. But you can look at from other side. Okay, what is happening to me? Okay, so it's like a movie, but you are watching the movie. You are not playing. You are not an actor in that movie. Okay, so that is what. But when into the experimental studies, you are also an actor in that movie. Okay, that is the difference. So these are the powerful studies, and it's you can read the history of this. And these studies, it's a really got its origin from cancer and Hill and Dolan Hill studies and all those things. It's basically, you can look at it. It's a cancer epidemiology. Basically, it's that time they did not call it as cancer epidemiology. Okay. Now, I have two slides about each of these designs. Look at it, case control study. It is an observational study. You start from here and you go back and you find many of such studies like that. You start from the population, you identify cases, people with a disease, and you identify controls, people without disease. Okay? Please be careful this word control. Yesterday, the RCT, when you use, there also there RCT, there is a control. Okay, that control is different from this control. Why I am telling is, many times I find people misuse this. Okay, the RCT control and case control, both are same. No. Okay, here the control means the person is not having that condition what you are looking, and case means having. You are going back on the time and looking at their exposure status. Okay. And then what do you do? The calculation is very simple. Exposure rate in this group versus exposure rate. It's not big magic or big statistics calculation. It's so simple. Exposure rate in this group versus exposure rate in this group. If there is a difference, then probably we can attribute that to the disease. Isn't it? That the disease we can attribute it. Okay, that is what that is a way beautifully assessed this one. In fact, if you look at Dolan Hill studies, it's fundamentally they have done this, and they have done what is the population they have done? That's the studies, case control studies. Huh? Good, great. Doctors, yes. Because in fact, it's good to read that those articles. Now it's available. Those articles. It's very clearly they said, yes, since we are doctors is the one. It's probably we get the questionnaire filled back. Okay, they send the questionnaire to all British doctors and got it back. It's okay. So what I am telling is, this exposure rate you can look at it. This exposure rate you can look at it and make a comparison of that. And that will give it, okay? And now I need, okay, this is the way the table comes, okay? Now, I just wanted, okay, for example, this is a table. This is a hypothetical table, it's not, I have taken it from a textbook. Only thing I wanted is, it is you know that, you had the statistics, it is a 2 rows and 2 columns, it is there. But I want some response from you. Is such a table and it is coming from a case control study. You look at it in the column wise or row wise. I need some response. It is coming from, you got the information, it is from a case control study. You look at this table, because it's in the cross-sectional also, you have seen similar table, 2 by 2 table. Okay, here you look at row-wise or you look at the column-wise. Huh? How many people tell row-wise you look at it? 1, 2, 3, 4, 5, 6. I think I can count you also. No, you, yeah, 6. Okay, how many feel it is column-wise? 1, 2, 3, 4, 5, 6, 7. There are few hands did not come up at all. What is anything? What do you think? Okay. Yeah, please understand when you analyze it, your design has got an impact on it. How did your recruitment happen? You cases you recruited, controls you recruited. That means you recruited this, you recruited this. Then you should look at that way. You cannot look at the other way, please. Okay? Because that is the way you designed your study. And then all of a sudden analysis you look at this way, that means no, you are you are doing some shortcut. You cannot do that. Okay? So you look at this way. That is why they looked at this way. Just look at it. This, look at this. Okay? And ratio of those two, yes, you know, the pretty beautiful measure, very simple measure, simple calculation, but so it made huge impact on the epidemiology. Almost every epidemiology paper you see this odds ratio, isn't it? And it is confidence interval. Okay? But why it is, this is a way you are looking at it, this one. Okay? And sometimes people call it as a disease odds ratio, or I mean this is a way. Okay? That's in the confidence. I am not going to the confidence level and all those things. Okay, that's it. Is it clear? That means, and this give, yes, a hypothesis test tell, yes, there is an association and association is strong, and what is the strength of association? It's much higher than 1, even confidence interval is above 1, so their association is significant. You get a proof to your hypothesis, okay, which won't give you cannot do this in the cross-sectional study. Even though you have a 2x2 table structure, everything is same, but if you do a test of significance, somebody can criticize you, no, you cannot, your study is not powerful enough to do that, okay? So what I am telling is, the table alone will give you, you have to look at who is behind that table, from which study it is coming, that table. That is very important, okay? It is something like that. Sometimes we have to look at our origin, from where we are coming. So like that, from where data is coming, you have to look at it. Without that, don't jump into the analysis, okay? So it has got a lot of merits and demerits. I am not going to talk much. That's you can read reading material. But case control study, why even Dolan Hill did it? Because it's even if you read that article introduction, they wrote it. It is so quick. So it is better to do it this one now. Okay, quickly we need some answer. There is an association or not. So they have done it. Okay. Then once they got enough about that, they move to a second type of study, which is called a cohort study. Just look at that design again. In case control, this was here, isn't it? Now I shifted the direction. Okay, time always move forward, but my investigation also forward. I looked at it. The people, first recruitment happened, people without the disease or condition. Okay, they are free from disease. Okay, that is the recruitment. And then that is a place you make an assessment about the exposure also. Recruitment time, they don't have the disease, but you make an assessment about exposure. Okay, exposure status, they look at it. Okay. Then there is a follow-up again. You follow them up periodically. It's exactly that the Dolan Hill later they have done. They have done, they wrote it in their cohort study like this introduction. Yes, we got enough from the case control study. Now doing one more case control study, it's not important. This is a time we have to do a little more wider study, a little more specific study. Then that the cohort is the best way to look at it. Okay, so what they have done is they send the questionnaire to the people and their tobacco use habit again to the doctors. They are not having the disease, but their tobacco use habit is identified and quantified. In fact, that original paper you look at it, that is a tobacco dose. I think many of you must have looked at it. They really, meticulously brought down the dose level of it in terms of grams. It's like that they brought into it. Okay, so and then over a period of time, it takes 5 years, 10 years, 15 years, 20 years. Okay, a long follow-up and develop the disease or not. Okay, this is what it's a basically cohort study design. Okay, this is a way it starts from here. These are exposed. And these are not exposed, okay? And then the calculation it is done here. Okay? And these the exposed, these many developed the disease, not exposed, these many developed the disease, maybe 10 years follow-up, and then 2 divided by 10, even you can, already I said the person years, how do you put it, person years of follow-up, all those things you can put it and can calculate it. Okay? It is not always you have to do person years, you have to justify for it, but cancer, I would say most often or always it is person years, that is the way it is looked at it. Okay? Now, you have this table, for example, I give another table. Okay? You have this table. Now, how do you look at it? My question, repetition, in the case control repetition. How many people look at it? I mean, there you can look at it column-wise, you can look at it row-wise. How many people look at it column-wise? No? Huh? Any hand is up? How many people look at it row-wise? Okay, lot of hand. Because it's good. This is a way. Exposure is the plus. First you observed it, you followed them up. That is the path you have to look at your data also. Okay? What I am saying is, what is your design? Okay? That should give power to the analysis. Okay? Otherwise, you look at it, the table is more or less same as case control table, more or less same as cross-sectional table, but the design, it is coming from 10 years work and case control came from 6 months work. You cannot look at the same way, isn't it? You 10 years work, you spend a lot of money, lot of energy, lot of human resources, and 6 months you haven't used that much, and at the end the data comes, it's both the same way you work, then what is the fun? You got it? So that is why you have to account for the design when you analyze your data. When you look at your data, that is very, very important. And then when you look at that, just look at this here, 75, this. So these many exposed at the beginning and followed up. Out of that, these many developed the condition. Okay? Compared to these many not exposed, these many developed the disease. Okay? So people who are not exposed also, they develop the disease. Okay? But people who are exposed to that condition more develop the disease, then you attribute that to that exposure. You got it? That is a way. It's a simple calculation. Don't think statistics is too much and nobody understands. It is a very, very simple logic. Okay? So this 75 divided by this and this 25. This 75 divided by whatever 20,000, you get it. Oh, sorry, there is this one zero is missing there, isn't it? Okay. What do you call it as? This 75 for 20,000? Huh? In incidence, isn't it? That is an incidence, it's called it as. It's not incidence rate. I did not include the time it is there. It's an incidence, okay? And the ratio of 2 incidents, you know what it is. It's okay. That is what relative risk it's called. Okay. Okay, when exposure is rare, it is very important. For example, many of the cancer studies, it is done this, okay. And one of the beautiful thing is it's a multiple effect of a single exposure you can study. That is a beauty of the cohort study. Okay, for example, a radiation exposure, and it's many outcomes you can study, not cancer alone. Okay. Many outcomes you can study, even many site cancer you can study like that, if it's a cohort, but you have to pay more for that, isn't it? The cohort study is not an easy, I don't think it's a postgraduate thesis, immediately one can take it. It takes long time to do it, okay? Yes, but rare diseases, it is inefficient for rare diseases, but why? But even cancer, sometimes you call it as a rare disease. Why it is inefficient? Huh? Because it takes long time to develop, and you have to have that large population. Okay, that large population you have, otherwise you don't get a rare disease. Means it's very rare, isn't it? So unless you follow up a very large population, that many numbers won't come. Okay, so these points are very important. It's in terms of examination, even Viva, somebody can ask this question. So be careful about that. Okay, is it okay to design? Stopped. I mean, each design is almost one coursework. I'm stopping with the 3 slides. Okay, I know that, but that is enough for your next after 2 weeks examination. Okay. Then another study this guy. How many people heard about this word, nested case control study? Huh? Nested case control study? One, somebody, okay. This happens, it is a nested case control study. I would say it is something like a shortcut in the cohort study, okay. You established a cohort, and cohort probably takes 15 years or 20 years, okay. And you have some curiosity, you don't want to wait that many years to happen, okay. So when enough number of cases get accumulated, maybe 3 years, 5 years like that, with the preconditions and a lot of other conditions are there, but enough number of cases get accumulated, yes, you wanted to, you have a curiosity, you wanted to look at it, how exposure and this one associated, okay. So from the remaining, you can subsample controls, you can do it, and these cases you get. What I am telling is, you are nesting, you are building up a case control study within a cohort study. You can do it. You can do it, and it is very powerful. Okay, and there are one occasion is the long duration. And the second is, for example, it's morning also sir was talking about genetic study, also saying large population you cannot do these investigations, isn't it? Within that, some of the investigation it's more expensive, all those things, only a subsample you can do it, okay? So cases you can do it definitely, and controls all 60,000 controls you cannot do it, so you subsample it. So those investigation, you are building again a case control study within the cohort framework. You got it? So ultimately your study is a case control study you are building up, but that case control study is even much better than the case control study of the other origin, okay? Because it's a cohort follow-up. Most of the information you know very clearly, very valid, very strong, because you were following up those things. You got it? And that is called nested case control study. Again, it's the case control study, that's the way it gets analyzed, but the power of those studies, information coming from those studies, because you followed up and you directly got all those investigation. It is not a retrospective investigation, so it is good. So that is usually you find long-term cohort studies, many nested case control studies built up into that. You find it's in cancer, it's very common, it is done, okay? So those are the major study design. In fact, I would say from the postgraduate's point of view, okay? Ecological studies, it's very rarely come. It's more, I would say, a statistical work, because it's basically, it is not a designed like that individual recruitment, it is basically a group analysis, I would say, okay. For example, the district statistics are available for all the whole country. It's not individual. District, for example, cancer, the incidence, it's each district of our country is available. Then overall we are looking at, and some hypothesis we are trying to evaluate. We are using the summary statistics only. We are not using individual statistics. Okay, so those are the things. It's ecological studies. It's come. And these are important in terms of policymakers. Okay, policymakers, it's very important. But other studies are more precise scientific thing. But generally policymakers, these ecological studies are very important. And many times quickly policy making, they do the ecological studies, because they cannot frame a cohort study for the next 20 years, because it's a ministry keep on changing and cannot get time to do things. So immediately next 6 months I wanted to implement something. Okay, we need something, it's more an ecological studies. It is not that precise, but it will give an idea about it. Okay. Experimental, I don't touch. Okay, that's you already had that experimental studies exposure. Okay, now one thing I wanted to tell you, I wanted to ask you is, yes, this again a 2x2 table. Numbers are not here. Okay, experiment. You know that now cross-sectional. You know the case control. You know cohort. Okay, and to analyze it also. Now you experimental studies also. Yesterday you might have seen this same table again a 2x2 table. How do you analyze? How do you look at it? Row-wise or column-wise? Row-wise. Now answer is very clear, isn't it? That means in the other way, other studies, which one you look the row-wise? Cohort study, isn't it? That means simple answer is cohort study and RCTs more or less analyzed the same way. Okay? Only difference is in the cohort study, my exposure I decide. Okay? In an RCT, who decides the exposure? Investigator cannot decide. Blinding won't decide. Randomization decide. Okay? Randomization process decide the exposure. Okay? I get which drug that random process decide. But in here, I smoke or I don't smoke, I decide. Now, that means it's where you go for a cohort and where you go for an RCT.
Natural one.
So where you go for an RCT, where you go for a cohort. If you are deciding something, can you randomize and allocate one group for smoking and one group for non-smoking? So now I have given the clue. Let's see how.
Normal person, without disease. Use and treatment.
Why you do an RCT? RCT some way, I mean, you are very clear there is a benefit, isn't it? For risk, you don't do an RCT, isn't it? There is a benefit. This exposure give additional benefit. Then you go for an RCT. You go for in the experimental. Okay? The moment you get a message, oh, this exposure give a risk, you are not allowed to do an RCT, randomization, nothing. But I know that it's smoking, it's okay, but still I continue it. What to do? But you can observe it. Okay, you got it? This clarity you have to have, that's it. Okay? Otherwise, analyze the cohort and RCT the same way you find an. So that is why it's a survival analysis you find for the cohort study, survival analysis you find for an RCT. You don't find survival analysis for generally case control studies. Okay? You don't find survival analysis generally for cross-sectional studies. You got it? Because there is a follow-up. Both its mechanism is there. Okay? So that is all the first part, including measurement, the basic concepts in the epidemiology. Before I go to the data, I'm not talking much about data. This anytime I can stop because these are more reading material, you can take it. But do you have any question? Anything in the epidemiology that area? Or shall I move? Huh? Okay. This is these are more reading material. It is about a hospital-based registry, or it's I mean, it's registry. It's mainly a very structured, organized way of getting data into place. Okay, that's because it will help you manage the disease, even control programs, it's various things. So, and it's overall divided into two, hospital-based and population-based. Hospital-based registries, it's basically talk about, it is a hospital-based registry. So it's more give about information, what is happening in that hospital and how it is, the followed up and prognostic also you get it. It's okay. And it stopped there. Don't talk more than that. Don't talk prevalence, don't talk incidence, don't talk all those things from a hospital-based registry. It is very dangerous. Okay, that's it. The basic problem with the hospital-based registry is the hospital-based registry is very important, and it will really give an indication about how your programs in the hospital it's moving. I mean, how effective it is, how the different type of cancer, its treatment mechanism, how effective it is. All those things it gives. That way it is good. But the major problem with the epidemiological problem with the hospital-based registry is you don't have the denominator, isn't it? Earlier rate ratio, all we said there was a denominator. Hospital-based registry, you don't have the denominator, so don't talk about that. Okay? Without a denominator, you in your thesis or when you talk about the prevalence or incidence, all those things. Yes, you are entering into the danger zone. You should not, because your study won't power. The registry, whatever amount you spend for that registry, how many human resources you spend, but it won't give power to talk about rates and ratios. It's okay. That is it. But that is why you have the population-based registries. It's started with the cancer registry. Now it's almost a stroke registry. There are so many registries. So the population-based registry, yes, basically trying to capture the denominator also. That is the basic difference with the population-based and hospital-based registry. You have a base population, a specified population, either it could be a district, it could be the country, or it could be the state. Like that, that is a denominator. You have a specified clear denominator defined, and then you are looking at, counting at how many developed and when developed and what mechanism it is happening. Okay, so that will give really incidents about it, and you have a beautiful data about incidents, and also the cancer registries are doing it's fantastically well for the last many years, and that is what. Okay, these are very. I mean, this now onwards most of the slides that I got from Dr. Swami, and more details you can get it. It's these are the locations where these registries are there, population based, and various rates are there. Okay. I'm not going to read all those things. These materials, you can read it out, and more details even you can get because that initial website, which the first slide I have shown, you can go to there. Most of these reports are available now. The summary tables are available, graphs are available, so you can look at that. Okay. In fact, it's some of the tables I looked at it. There was a WhatsApp for particular different sites. We need these rates, adjusted rates, and all those things. Okay, so the whole data it is there. Okay, that you can read. Now I don't spend much time on those things. Okay, so that is about the data part of it. You read it. But definitely there will be a lot of questions will be there. You have to look at it. Somebody will ask you incidents. It's for different cancer registries. It's what is the incidence, or different sites. What is the one type? What is the one? And all those things. It's okay. Now last I think it's 2 or 3 slides. Here I just wanted to touch upon again. There was one. I think it's WhatsApp asked for this this part of it. So how this cancer data, or I would say it is more in the cohort type it comes. That is what is the problem, because you are dealing with a more a chronic disease. So it's a follow-up, it is required, time is involved always in it. So that data has to be analyzed in a different way. So you are, it is, I would say, you are more towards a movie than that of a photograph. Okay, a photograph is more a cross-sectional one. But you are with a movie. There is a starting point, a follow-up over a long period of time, and what is happening. That movie, that is what you are looking at it. Okay, so that data. And second point in the cancer data is, or any chronic disease data is, time is very important. That means even if the exposure is same for 2 individuals, it is not they both develop the same duration the disease. That is same way, even 2 individuals you treat, it is not they both get cured the same time, isn't it? Your treatment mostly not short-term treatment. Even if treatment is, for example, chemotherapy is short-term, but the follow-up is long-term, isn't it? Okay, because it is not like that within a week of chemotherapy get cured, disease get cured, a long-term follow-up. So you recruited 20 individuals or 100 individuals or 200 individuals, you treated them with the same drug, everything is same, but it's not their response is the same. I mean, they're disease-free, the same. So what you are telling is, you are telling, it's not I am telling. You as an oncologist, you are telling, this disease should be looked at differently, because time is an important thing, because different people respond different duration. Okay, and some people won't respond at all. That also accounted for analysis, and that is why for this one a separate analysis setting is made. That is, it is basically called, what is this KM? I put it as KM. What is it? Okay, all of you are familiar with that. Okay, survival curve. The reason is it's okay. There are something called adjusted or standardized rate or survival curve, and you can do comparison as well as it's a Cox regression. These are the commonly used. One is adjusted. Somebody asked, that is why I just got a slide into it, how to adjust it. What is okay, how to adjust, calculation is there, you can do it. But I tell you the concept. The thing is, you look at incidence of cancer, for example, in Kerala, okay? Incidence of, take care of lung cancer in Kerala, okay? And you look at incidence of lung cancer in Meghalaya. And crude incidence, you know how to calculate, and you make a comparison. What could be the problem in that? I said 2 states. One is Kerala and one is Meghalaya. What could be the problem? I am not talking about survival, incidence I am talking about. So how long the fellows in the Kerala, life expectancy, it could be much different from the Meghalaya, isn't it? Okay, for example, it's all of a sudden you get incidence, overall crude incidence rate, if you calculate, Kerala incidence is more than Meghalaya. The reason could be their population, the structure, age structure is different from population age structure of Meghalaya, isn't it? So directly comparing these two incidents is not right, okay? So that is the place. So if you want to calculate incidence of Kerala, that is all right. But if the comparison, when it comes, there is a problem. If you wanted to make a comparison, that one, then you have to standardize for the age. That is the concept, okay? So suppose this is the question. Suppose the age distribution of these two places are same or similar, what would be the rate? That is what standardization. How it is, calculation, everything is put. But the concept is this, suppose these two places would have the same age structure, population age structure. So it is an artificial thing you are bringing inside, okay? Never it will be same. But you are bringing an artificial thing inside, okay, this structure is, both places have the same structure, okay? Then what would be the rate? So same structure to bring it, your standard population you have to bring in. That is why there is always adjusted rate when you calculate, you bring a standard, a third party inside. Okay, that is artificial one. That is actually creating an artificial one. Okay, so third party inside, then you calculate but okay, Meghalaya's population would have been the same structure of the standard, what would be the rate? That is what we got it. And the Kerala's population, it's the same structure, what would be the rate? Both you got it for the same population structure. Then probably this comparison, the last one, this and this is comparable. You got it? The concept of standardization or adjusted is this. Okay, that is all. Whatever age or whatever it is a direct adjustment you are doing, but an artificial factor you are bringing into it. Okay, but is it okay? So this is only one slide I have for that. Then next is, you know this curve. What is this curve? Yeah. So this is a story, like movie it is telling, and how much this is very fast it is coming down, it is very slow it is coming down. Both are almost came down at the same time point, it's near. But this is a fast runner, this is a slow runner. And how the difference is compared? What is a test you use for the comparing this difference? See, they reached the same point, okay? Almost the same point, but this is a fast runner, this is a slow runner, okay? How it do? Log rank test. Log rank test is the one test, it's used for the comparing these. I don't want to talk more about this, it's only one slide, okay? You can go and read more, but examination this is enough, okay? Log rank test, you tell it's okay. Now, next one more point I wanted to tell is, it's this, don't look at those equations, all those things, okay? Now all we talked in terms of something like a direct comparison, probably this is the last session of it, it's okay. And I said the age adjusted or like that direct adjustment, okay? You find when you do a study, a cohort study or a case control study, or it's when you do a RCT, yes, you are giving two group interventions, but there are many covariates. We call it, have you heard of the name covariate? Covariate, how many heard about the name covariate? Covariate? Don't feel shy. Okay, this is a platform you ask. Okay, Covariate, okay, covariate means additional variable that also has got an influence on the outcome. Okay, how to take care of those variables? That also statistically we call adjusting for those variables. Okay, and in this type of longitudinal data, this type of follow-up data, we have a beautiful method. You are aware of this called a Cox regression. Okay, that is a one method. It's developed by D.R. Cox. And that is very beautifully applied, and it has got a lot of advantages of it. It will get away from the time factor, even though you use the modeling time on those things. Basically you can forget all those points I said, but one point you have to remember is, yes, the adjusting for other covariates and making a comparison between groups, yes, it is done by Cox regression in a follow-up study. That means either it's a cohort study or it is a intervention study. Wherever it is, you have a two comparison, either two group comparison or many covariates. You wanted to adjust for that, and you wanted to find, for example, effect of treatment you wanted to find after adjusting for few other covariates like age, gender, like that, many other covariates. Okay, the method we use is called a Cox regression. It will take care of the duration as well as, if duration is not there, then you can do a logistic regression. Okay, here logistic regression, because duration is very precious and very important for you. You have to do it. Okay, so okay, these things you can call. I mean, it's you can read it, but one of the I said relative risk, I said odds ratio, all those things. The Cox regression, what it gives, like a relative risk or something else it gives, you know. Anybody can recall? With that I can stop. Another thing, have you heard about the hazard ratio? Huh? So from where it is coming, anytime thought about it? Huh? In papers you saw that. Okay, because I don't think it's any cancer, I mean research, especially studies, it's I mean you end up without a HR. Okay, but from where it is coming, what is the corresponding analysis for that? Huh? Relative risk. You call it as a relative risk. It is not relative. You call it, but actually hazard ratio. But from where it is coming? Is it is coming from the earlier one ratio of 2 incidents? No, it is from here. Okay, so you should look at it. That is analysis. Okay, that's the place I stop. Okay. I don't know, I exceeded more time.
Thank you, sir. So after each time a biostatistician talks, the respect towards them increases. Because you learn new things every time, and we have a lot of things to go back and read. That's one thing I can tell you. And many of them can be short notes that have really consolidated the concept part of it. We will share the presentation as well as his video link so that for us to understand better. Any quick questions to sir?
I think I asked many questions. Yeah, but I think he's asking.
Mean PFS and median PFS. When we interpret mean PFS and median PFS, which is more important?
Okay.
The difference between mean and median.
Yeah, I'll tell you. Especially with this long-term follow-up, one of the thing is many of the observations it's incomplete, isn't it? So actually, it's to calculate a mean. Really, you need complete observations. And in our follow-up studies, and very often and always our cancer studies, you have censored data, isn't it? Hardly you have a data set which are censoring. Censoring, the basic meaning is it is an incomplete information. Some part is missing. Then ideally you cannot calculate mean. But even if it is missing, you can calculate median. That is why always you report median. You don't report it a mean. Okay, that's a.
Thank you so much, sir.